our first speaker, and we are very proud to have Professor Joy Lawn here. She is a very well-known and world-leading perinatal epidemiologist, professor of maternal and reproductive and child health at London School of Hygiene and Tropical Medicine. Welcome, Joy. The stage is yours.
Thank you so much. Thank you, everybody. Such an honor to be here, and also happy to have the clicker back. My main qualification really is that I should have been a newborn death in Africa. And what I want to talk to you about today is what Swedish researchers can do to make sure that doesn't happen to anybody, if hopefully my PowerPoint can open. Okay, as I was saying, so 134 million newborns, research gaps, and what can Swedish pediatricians especially do to close that gap? So I've got some tips, some topics, and a little bit of a flavouring for World Prematurity Day because we're leading up to that next week. So I want to start with 134 million newborns, live-borns. So we've passed the peak of world population growth, coming down now, 10 million less than even a few years ago. So every baby counts even more, or should count even more. And amongst those babies, about 30 million need special care, especially driven by preterm in high-income countries, but around the rest of the world, there are many babies who aren't preterm who need special care. Small proportion in Europe, and especially small proportion of the deaths. But not all born equal. So just off to the left of this slide, you can see high-income countries. So most of the evidence, most of the focus, and almost all of the research is still in these contexts. Cochrane reviews are on micro-gain in these contexts. Increasing proportion of births in upper middle income countries. Countries are graduating, especially big countries, obviously China and India are here now. And in many cases, we actually have over-medicalization. Brazil, I was there a couple of weeks ago, 53% of births are C-sections. Babies are taken away, mothers are not often really enabled to be in units. So we have coverage, but a gap in quality, and especially for families. Low-income countries, we have these two splits. It used to be more births were at home in this invisible world. You can enter and leave the world without one piece of data. But we have this big shift into facilities. 50 million births now happening in facilities in low and middle income countries. If you were to pick one place to focus, this is the place. Because we're now brought them into hospitals, we're not doing the right thing often for women, and we're really failing the babies big time. So this is a key place to focus and where we can change things. But what we need to remember is we cannot just take evidence from here and drop it to here. We will do harm. And we see that with head cooling trials, with other things. We need to really take into account context. So then if we move forward to what does that mean for our targets? We're here now with 134 million live births. We're at the half point of the SDGs. And the score is unacceptable. So we still have almost 300,000 women dying, very preventable deaths. And if we shout for babies, we must shout for women, otherwise we fail. We still have 4 million child deaths after that first month of life and before the 20th year. We have 2.3 million newborns, which is the focus here. That's the latest data. And they're on the agenda not because parents have power, and actually not usually because of us as the healthcare professionals. So the socio-political scientists have told us we're actually too nice. We're not like the HIV people. We didn't get these babies on the agenda. What got these babies on the agenda is having targets, being part of the Millennium Development Goals and now having a specific Sustainable Development Goal target. Stillborn on the global agenda are the stillbirths. They are almost an equal number, and this is stillbirths in the last trimester from 28 weeks. So for WHO and UN comparison, we compare from 28 weeks. Data should be from 22 weeks, and we compare from 28 weeks. There isn't a sustainable development goal, but there are global targets, and there are countries with targets. It's not the focus of today, but we will lose the plot if we don't also count them. Really critical. So this is a total of 9 million deaths still. Unacceptable score that we need to put together and be clearer about. And 50% of those are now around the time of birth. And every time we switch on the news, it's heartbreaking around the world. And we need to remember that in all these crises, the most vulnerable are pregnant women and babies, utterly critical. And we need to do a better job of using that data for change. And then what about place? The time is closer to birth. The place is more and more on the continent of Africa. So Africa is about 13% of the global population. But unless trajectories change, by 2030, it's going to have about 3/4 of the deaths for women and children. Partly from population growth, but particularly for lack of progress in risk for deaths. And this is notably driven by Nigeria, the giant of Africa. But only about 2% of global research writ large has any African author. And if you look at the details, so for example, this very powerful paper in BMJ Global Health stuck in the middle, they're also not getting the recognition for research from their own countries that they should get. So utterly critical that we who believe in justice and global justice don't just recognize this data, but we intentionally shift what happens for that. And I really want to salute Swedish researchers, and particularly Stefan and the partnership with Makerere, for intentionally trying to shift that. And if you were to pick something that you do in people power, this is utterly critical place to walk alongside and to lift people up. So I want to talk to you about science gaps. And particularly when we come to the newborn, it has to be interdisciplinary, true interdisciplinary, not just multidiscipline where we put a few different people on a team. And I love this statement. To get the biggest challenges addressed, we need to have unlike minds. And to do that, we have to listen to each other. And that is utterly critical, getting beyond our bubbles. So I want to talk to you about these types of research, delivery, development, and discovery, with most focus on delivery, a little bit about the concepts, and some things on ideas. Obviously, in this amount of time, we can't go into detailed topics, and there'll be many things we can't do in detail. But before doing that, I want to, first of all, just give 3 top tips, really from my own learning and offered in humility. I still learn stuff every day. So what have I learned in 30 years of walking this walk, with most of my time based in Africa? So some tips. First of all, pick the big what. Don't pick tiny whats. Be brave. Then think about the how. What's your question, and what do you need to do to address that? We don't always need randomized trials for everything. And then thirdly, money talks, and even more so when politics messes up our money, right, Tobias? And most important, team. So in everything that we do, team is really the most critical tip. Intentionally building research leadership. When we die, it isn't the number of papers that people look at, it's the team and the people around. Intentionally transferring that. And this is something I learned from my husband. There's no I in research, right? It's research. So if you forget everything else, remember research. It's no longer research. So first of all, big burden. So Hans Rosling, of great fame here, also often talked about how people lived in data from the past. I like to say we live in a pie from the past. So most of the people who make decisions for funding live in a pie chart where child deaths are all caused by AIDS, diarrhea, and malaria. That's the pie chart that funders live in. That is not the pie chart that we have. So this is the most recent pie chart, and you need to remember the numbers change every year and the causes change every couple of years. And for almost 10 years, the top cause of death for children has been preterm complications. And that's direct preterm complications. It's not deaths among babies born preterm. That's dying of RDS and direct complications of preterm. So infections, still unacceptable deaths from pneumonia. We're not competing with them. They shouldn't happen, nor should diarrhea. But now, 48% are in the neonatal period, and another 3% are from neonatal complications. So the majority of children die from neonatal complications. So these are the top leading causes. They interact, right? We know as pediatricians. So the whole group together, we're trying to call small and sick newborns. Of course, it's neonatal care, but by humanizing it and making it sound a little bit more possible, we're really trying to make a big drive to get it scaled up. And I want to underline here that congenital conditions shouldn't be left out of the big causes now. It's really up with the preterm, intrapartum, and infections. Congenital is really critical to take into account. So if we just have a couple of slides on the preterm side. So there's a lot of new data on preterm. I'm not going to take you through any of it. I want you to watch this horrible flashing thing here, which shows that it's a flat line for preventing preterm birth. That's the single biggest message. We are utterly failing on preterm prevention in high-income countries as well as in low and middle. And that may be because some of the risks are shifting, for example, climate change. But we're not doing the right things for preterm birth prevention. You can look these things up afterwards because we don't have time to go through them in detail, but there's a lot of new data, especially on small for gestational age. So we need to not just assume every small baby is preterm, particularly in South Asia, where term small for gestational age is big. And that, in the IKMC trial, may have been a factor in different results in different places. So to address preterm birth, thinking of World Prematurity Day next week, we need critically to both prevent and to care for. Across the world, what we've done very well is caring for, right? That's all you guys. Like, we leap on babies straight away, we attach them to hundreds of machines, it's all fantastic. We need to also do better on primary prevention, and that's not always in our control, and it's also beyond the health sector. But we need to think about this and address and move on it more. But the thing that's in our hands that's a huge inequality gap is this survival gap for babies born preterm now. So the biggest place to focus in hospitals already, and this gap. This is a place where we can make impact, and we need to think about how to do it, but it's also not drop one thing from the sky. So it's more complicated. So this is unacceptable inequality, but the good news is it's also a major opportunity for impact, and impact fairly quickly if we did the right things in the right way. But that will take a bundle, of which the highest impact things in the core bundle would be CPAP and KMC. And this Born Too Soon report that we launched in May of this year, and Bo Jacobson from Gothenburg was also involved in this with about 140 individuals, many in the room, many organizations, very high level agency heads, and massive media coverage, right? Why does it get massive media coverage? It's because this affects every family in every country. It's 1 in 10 babies. So every journalist knows someone who's had a preterm baby. The stories come from the stories. So we need to remember that actually, just like with HIV, what gets things onto agendas is not just the numbers or the solutions, it's actually the people power. How we got an SDG for newborns was the US preterm parent group. It's not the power of parents and governments in low and middle income countries. So we shouldn't neglect the real power of human stories. And then how do we take that forward? So the question then is, what is the question? And it's really critical. All of us know as researchers, if you start out with the wrong question or the right problem but the wrong question, you won't get there. And how do you answer those questions? And we haven't got time to do this in detail now, but I just want to flag to all of us, I started my journey as a neonatal clinician as well, that actually for us to test the things that matter in complex interventions, we need much more skills in complex evaluation. And I've learned so much over the last few years on this. So complex intervention, what is it? This is the definition. So our package for small and sick newborn care includes all of these, lots of components that interact, lots of different changes, organizational, multi-level change, flexibility by different contexts. Every single thing in this fits what we do for a package of neonatal care. And so because of that, we need to think more about this designing of complex evaluations. Not everything will be an RCT, so you have this kind of different approach of designs, but also many other options in the armamentarium. And there are people who spend a lot of time on complex evaluation. We need to find a way to make complex evaluation less complex, so it can be led from Africa as well. And to do that and to do it more consistently. And this is something we're really trying to do across the Nest 360 Alliance in 5 countries in Africa, and we would welcome partnerships on that. So I think this is a critical area to build up more skills on. And then for the last tip here, I want to talk about money talks. So we published 2 papers in Lancet Global Health a couple of weeks ago with a big group of authors. Spoiler alert, both the donor and the research funding is still tiny for newborns and minuscule for stillbirths, but it's actually still quite a lot of money. So, just because it's a small proportion of a very big pie. So the first thing we need to do is argue for that to be spent smarter. And if we do that well and use that well, then more money can come as well. So I don't have time to even really mention the donor funding. I'm hoping that Stefan will take something on that. But I want to give you a couple of slides on the research funding, and then I would really encourage you to read it and think how you can use that to make the case in Sweden, both for you to get more money, but also to hold your funders accountable, because that is why we did these papers. So I'd never heard, who's heard of Dimensions AI? It's not just a papers database like PubMed. It has all the grants, scrapes them all up. Any grant that is mentioned on the internet gets scraped up by this, including like China, Brazil, India. Of course, sometimes big pharma doesn't put things on the internet, so that's missing a bit. But actually now more than 6.5 million grants. So we analyzed this with a bunch of young pediatricians from around the world. To cut 2 years of agony short, here's what we found, and you can read more in the paper. So basically, there's 557 million a year spent on research that mentions newborns and stillbirths. It's actually quite a lot of money. Most of that money is on newborns, not on stillbirths. So even in countries like the US that has 20,000 stillbirths a year, they never mention stillbirths in research that actually probably does impact stillbirths. So it's actually a missed opportunity for funders. The argument to funders is not, you bad person, you didn't mention stillbirths. It's, you're missing something that could claim you more impact. So we need to be smart in how we make the case. And it's really a reflection on stigma, particularly for women who have a stillbirth and lack of voice, that stillbirths aren't there. So we need to find smarter ways to get stillbirths into funding. And then there's a horrific geographic mismatch. So of this money, only 7% is spent in low and middle income countries, although 98% of the burden is there. Most of that 7% is actually from low and middle income countries as well. There's a ribbon graph in the paper that shows that. And there is money spent on people and capacity. We split that out in a column in a table, most of which is in high-income countries. So that money, we should be spending more of that money also, particularly in the African subcontinent. And then we looked at 10 years of funding for low and middle-income countries. The good news is it's gone up a lot. And in fact, most of that is BRICS countries. China is a big funder. Brazil, India, starting to fund their own research. Good message, but also bad message that the high-income countries are not spending, or they're also only giving it to high-income countries to spend in low and middle-income countries. That's also a problem. So these are the top funders. Don't have time to go through it in detail. Not a surprise that Gates is at the top, and we salute them. But we note that most of their money actually goes to the US for low and middle income countries. So we also need to look at how these things work. And in the middle here, you can see China, Brazil, and India really taking up a lot of leadership. So if we look at the topics, good news is that in low and middle income countries, the topics that are funded for research are mainly neonatal infections and preterm birth. Actually, very little on hypoxic ischemic encephalopathy, neonatal encephalopathy, very little on congenital abnormalities. The research pipeline, 50% nearly is on basic science and 3% on implementation. So we know that where we will get impact now is on this end of the pipeline. Of course, we need things at the other end, but this is an imbalance for impact. So then if we move forward into that delivery research, what are the important things for all of us and for the Swedish newborn research community? Well, I want to start by saying we must go faster. So for most countries, there are 63 countries off track for the neonatal target, now only 6 years away. They need to go at least 2 times faster. Most of Africa needs to go about 3 times faster. Nigeria needs to go 10 times faster. Scary, right? So to go faster, we can look at the evidence, we can also look at history. Lots of things we don't want to learn from the UK. I'm like a fake Brit and I'm able to call it. There are lots of things we don't want to learn from the UK. This is the UK and the US neonatal mortality rate over time. The target for low and middle income countries is 12 per 1,000 live births. They hit 12 per 1,000 live births really just as neonatal intensive care was coming into scale. So really critical to say how, in this very short amount of time, can we go faster, actually, than the UK and the US did. So this early phases, where you have high neonatal mortality rate, you can do things in public health, tetanus, cleanliness, immunization, infections, start to improve obstetric care, immediate newborn care. To do these phases, you have to have better obstetric care, and you must have special newborn care, and you must move into respiratory support. And then this is where most high-income countries are now, and also where China is now. So China is #1 for reducing neonatal mortality rate around the world. Over 8% per year still going fastest, even though they're now down at the bottom. India has gone from about 1% per year to almost 5% per year, linked to the time period they scaled up small and sick newborn care across India. So in Africa, in the next 5 years, the big push is small and sick newborn care, and doing that in a way that is intentional. So most of Africa is in this belt here, 15 to 30. These are now the fastest moving countries in this belt. And all these fast moving countries had recent scale up of small and sick newborn care. But of course, if we're in this kind of context where you have much higher mortality, you should be doing the other things before you get to small and sick newborn care. You need to do the basic essential newborn care and the basic public health side. So then we need to think about the package. So one of the learnings from immunization and HIV is if you make your package too big and too complex, you can't scale it. It needs to have enough in to have impact. But if you start adding surfactants and head cooling and complex things, you actually slow down reaching everybody with the core package. So this is the core package from WHO, which we need to focus on. And this baby shows us why we need to focus on more than one thing. So unfortunately, the little video clip isn't working. But this baby, Chikonjetso, 1 day old, to save him, we can't just drop KMC alone or CPAP alone or whatever alone. We have to bring a package of interventions, and that takes systems change, and the systems change goes beyond the newborn ward. You can't just do data on the newborn ward, it has to be part of the national system, and so on. This is Chikonjetso 2 years later. So we always just need to remember as neonatologists, we're not just here to graduate the baby off the newborn ward, right? They need to survive and thrive, and we're not doing enough to measure that. Lots of work needed, and I know Ashish is doing exciting stuff in this area. But one place we're utterly failing is thinking about retinopathy of prematurity. So across Africa, across Asia, we are generating an epidemic that we're not even measuring. And this is an area maybe that Sweden could contribute to. There's work linked to Claire Gilbert and others simplifying detection and follow-up, and we need to think, how do we do this and how do we make it work well? Another thing that we need to think about in all our studies is how do we have longer-term follow-up? Because we need to be answering the questions people will ask 5 years from now, and policymakers are already telling us we're generating a generation of disabled kids. So we need to be able to answer that, because disability is preventable as well as deaths. And we need to be measuring and thinking about that and preventing it and showing. So this is really critical to take into account. How to implement faster? Stefan will be taking this in more detail. But to do this, we need to be thinking of the package overall. And WHO and UNICEF have this 10 core components. What we have found across Africa is everybody is reinventing the wheel for each of these. Floor plans, education materials, and so on. So together, we have developed this implementation toolkit website, which this year has 10,000 unique users, been translated into French, and has 700 tools on it. We would appeal that anything you learn, share it here. Things that you want to suggest for webinars, let us know. If you speak French, particularly get in touch. We're really trying to up the French side of it, because French West Africa gets left behind. So please, please do join, support, add to this, and bring ideas. This is the Nest 360 Alliance. It's one of the most exciting things I've ever had the privilege to be part of. So 5 African governments, just about to start across Ethiopia. Most of the organizations are based in Africa, really trying to put the African leadership at the front of everything that we do, and looking at the systems change with a core data set across lots of hospitals so people can drive each other's quality improvement. This is across Malawi, everybody's favorite small African country, right? 27 districts, now 37 neonatal units. And those neonatal units vary dramatically from a tiny room to a full space. We're able to look across health system building blocks in a comparable way on what's happening for space, for nurse ratios, day and night, for power outages. You can't do CPAP if you have power outages all the time. Big problem. And how do we solve that? So there's a lot of really exciting work going on. But most importantly, live data dashboards on the ward for people to use. Shouldn't just be collecting data to go somewhere else. How do you drive change there? And how do you enable people to interpret those and use them? This has really been so much learning. And we find things that you think are really basic, like 2/3 of babies are freezing cold on admission despite trying to do immediate KMC. Infection outbreaks that we're missing, so across these 37 hospitals, there are only 5 of them that are doing blood cultures. All of them could. All of them have labs that they could. So why is it not happening? Some of it's a culture of doing cultures. So how do we use data sets like this to try and detect outbreaks even if people aren't doing blood cultures? And this is a hospital that does have blood cultures, but that still wasn't flagging outbreaks. Here's an outbreak with 90 deaths 85 with gram negs that was only found afterwards on the data set. So this is an area definitely where Swedish colleagues could make a difference. We're having, deaths in large numbers from preventable hospital-acquired infections. The money is utterly critical, and making the case much more smartly. I'm going to Tanzania next week, where now the president is paying attention to neonatal mortality. Just last year, following this investment case done with the government put in 30 million of their own money, including for rebuilding or building new neonatal units in rural areas. So making a case is utterly critical, and we need to flip it from being charity to being return on investment. So for every $1 in, between 8 and 12 back, just on deaths averted, made a very big difference in the discussion. We also need the people. The money case needs to make the case for more people, not just more space and more devices. We have really failed to ask for the right space. If we want respectful care for women, for babies, if we want to do immediate KMC and bring mothers into the unit, we need to recognize we can't just have a tiny room. We need a bigger floor plan, and we need people to build the right spaces. You have beautiful places built here. We need to also not have charity spaces across Africa. We need to make a better case for infrastructure. And when we do that, both the nurses and the parents and everybody celebrates more. This is a unit in Tanzania. We're a little bit low on time because we lost some time at the beginning, so I'll go very quickly through this development part. Neonatologists love devices. I could not go back to ventilating 24 weeks again because all the devices have changed. And if we love devices, we actually have to love biomedical engineers. So in Nest, I've worked closely with biomedical engineers. I've learnt so much. And if we don't love them, all our machines end up in an equipment graveyard. We have too many donated machines. We have like 5 different makes of everything, 5 different CPAPs. You have to train 5 times, have 5 sets of commodities. Just doesn't work. We need to be much more rational in how we bundle devices, which ones we have, and how we make sure they work. And I would encourage you to go to this website, the UNICEF Target Product Profiles for what type of device. And we need to think carefully about, are they robust enough? Don't just take devices that work in Karolinska and hope they're going to work in rural, wherever. We need to actually have devices that are set up to manage power outages and so on. And there's a device costing and planning tool. On the development side, a critical gap is drugs. There's only ever been one drug developed specially for newborns, and that was surfactant. We have drugs that have been relicensed like caffeine, but we just can't get them. So we need to do better with this. What about diagnostics? So if you're thinking of new ways to change things, and I can share these slides afterwards, these are critical gaps for neonatal diagnostics. And I think a huge one is especially on the infection side. Even if we got people to do blood cultures, they're still not what we need, right? We need to do better. So how can we get, multiplex PCRs that work or are lower cost? There are Klebsiella vaccines coming from different groups now. And obviously preterm birth is key. Our innovations aren't just devices, they have to be health system disruptions. And I think KMC is one of the best examples of a health system disruption, putting the woman and the baby at the center instead of the machines. And the picture for that has changed over time. And the picture of this happening in high-income country units has the best is a good way to argue for it to happen everywhere else. So that reverse innovation is key. And we've just closed a trial in Uganda similar to the IKMC trial that's under review at the moment that has a lot of interesting learning also on the economic side. So just one slide on the discovery science and then I'm going to close. For the discovery science, maybe we aren't the people who are in the lab, maybe some of you are. But we absolutely need to not compete with discovery science. We need to inform them. And this is a very good example. So after 40 years of Group B strep, people talking about giving the world lots of antibiotics, we realized that giving 20 million women who have GBS carriage antibiotics every year may not be the best way forward. And in fact, what made the case here for the cost effectiveness was including stillbirths. So by adding stillbirths to the cost effectiveness for GBS vaccines, there are now 2 that are going into trials, including one that's actually come from Denmark. So very exciting, this is coming. But a big problem here is we have no GBS surveillance. And obviously, disease-specific GBS surveillance will fail. So we need better neonatal infection routine surveillance, including organisms. So when I land with this, research, what can Sweden do with others around the world to really change this? Pick the big burden, measure the right things, think from the beginning about systems change, think for scale right from the start, think of the question and ask your question with the right design. We need to be smarter on the money. It's not just going to land on us. We need to hold people accountable. We need to get the money that there is available used better. We need to build teams, and especially we need to intentionally support leadership from the highest burden countries. And together, I'm sure we can do it. Thank you.
Thank you so much, Joy. We are running a little bit late in our tight schedule, no problem. But since you are in the panel, I think we can save questions for you to then. Okay, so we move